Hello. Thank you for the opportunity to present Signs and Symptoms of Sepsis. Early detection and identification saves lives. September is Sepsis Awareness Month. My name is Lee Harden, and I am an assistant professor at the Moffitt and Sanders School of Nursing at Samford University in Birmingham, Alabama. I currently teach nursing administration courses in the Postmaster's DNP program. I began my nursing career 21 years ago, and my clinical experience includes leadership and management in the neonatal intensive care unit, adult critical and acute care, and inpatient rehabilitation. I began teaching 9 years ago. My teaching experiences include undergraduate and graduate business administration courses, as well as undergraduate and graduate nursing courses.
Hello, everyone. My name is Lisa Gurley, and I'm an associate professor of nursing, currently teaching in the Postmaster's DNP Nurse Administrator program with Dr. Harden at the Moffitt and Sanders School of Nursing. My clinical background is adult surgical, intensive care, perioperative, and community health nursing. Most of my teaching career has been in undergraduate nursing, including facilitating medical surgical clinical experiences, and I have been a nurse for about 25 years. Dr. Harden and I have no conflicts of interest to disclose. The purpose of this presentation is to provide an overview of sepsis disease process, review Selye's general adaptation syndrome, identify populations at greatest risk for sepsis, increase awareness of sepsis signs and symptoms, and facilitate timely sepsis diagnosis and initiation of treatment. By the end of this presentation, participants will be able to apply Selye's general adaptation syndrome to sepsis disease process and discuss the sepsis disease process, including risk factors, signs and symptoms, nurses' role in timely diagnosis, and nurses' role in implementation of treatment.
I will begin the presentation by providing an overview of sepsis. Despite advancements in technology and infection control practices that have dramatically improved the incidence of sickness and death associated with many disease processes, one adverse health condition continues to pose a serious threat. Bloodstream infections, or sepsis, remain a leading cause of hospitalization, morbidity, and mortality in both developed and underdeveloped countries worldwide. Even though sepsis is believed to be preventable and treatable, the incidence of sepsis-related disability and death has seen a steady increase over the past few years. This surge in rates has since led to the formation of standardized medical interventions aimed at reducing the progression of complications that are highly correlated with the diagnosis of a bloodstream infection. The implementation of sepsis treatment bundles has proven to be highly effective at reversing the sequelae associated with the disease process. However, outcomes have not improved as was hoped. The evidence suggested that opportunities with regard to symptom recognition exist, and that a proactive approach to include the early identification of sepsis-related symptoms is needed to ensure that treatment is initiated in a timely manner. Healthcare providers around the globe have taken notice of the problem that many are now referring to as the silent killer. It is referred to as a silent killer because many of the symptoms that manifest as a result of sepsis can be confused with or related to other medical conditions. Sepsis is the body's extreme response to an infection and can result in a life-threatening medical emergency. Sepsis occurs when an infection that you already have, for instance, on the skin or somewhere else in the body, is not treated timely or effectively. The infection spreads and triggers an inflammatory response throughout the body. Evidence has shown that without early recognition and timely treatment, sepsis can rapidly lead to tissue damage organ failure, and death. In most cases, sepsis is caused by a bacterial infection. However, it can be a complication of other types of infections, including viral infections such as COVID-19 or influenza. The CDC has found that 4 types of infections are most often associated with sepsis. They are lung, urinary tract, skin, and gut or abdominal infections. Sepsis is non-discriminate in nature as to those who may be affected. Many well-known individuals such as Muhammad Ali, Pope John Paul II, and the Muppets creator Jim Henson have died from complications related to sepsis. Sepsis is the most significant contributor of hospital admissions and subsequent death around the world. If not identified promptly, can lead to a respiratory and circulatory collapse, is associated with high rates of morbidity and mortality, leads to increased length of stay and an increase in cost, is considered to be preventable and treatable, and is the leading cause of death and disability for hospitalized patients. Unfortunately, even with the development of innovative technologies aimed at treating sepsis, the identification and treatment of the infection-related sequelae is often delayed. Patients often present to the hospital with dehydration or other symptoms that are commonly associated with other conditions, which may mask underlying sepsis. Each minute that a regimen of care is not initiated, the risk of mortality invariably increases. In 2017, there were 48.9 million cases and 11 million sepsis-related deaths worldwide, which accounted for almost 20% of all deaths globally. So roughly 1 in 5 patients diagnosed with sepsis died. In the United States, sepsis was ranked the 11th leading cause of death and accounted for more than 1.8 million hospitalizations and resulted in nearly 270,000 deaths. When you look at these figures, they are staggering, considering that sepsis is considered to be both preventable and treatable. These figures are also pre-COVID and are slated to be even higher over the coming year as a result of the recent COVID-19 pandemic. The incidence of sepsis is highest in the southeastern United States. Sepsis is the 10th leading cause of death in Alabama and accounts for 17% of the state's mortality. Deaths occurred most in Black and brown raced individuals and females between the age of 75 and 84. In Jefferson County, Alabama in 2014, roughly 19% of the deaths in the county resulted from infections. Alabama is ranked 3rd in the nation for sepsis-related deaths, which represents a sepsis mortality rate of 16.8% per 100,000 of the total population. The risk factors associated with sepsis include age. Children under the age of 1 and elderly adults are most affected. Those who are already ill due to an infection, those with a weakened immune response or system, and individuals with pre-existing conditions such as diabetes, lung disease, kidney disease, and cancer. An evaluation conducted by the CDC found that more than 90% of adults and 70% of children who developed sepsis had a health condition that had put them at increased risk for developing sepsis. Additional risk factors include impaired skin integrity, having indwelling devices such as urinary catheters, IV catheters, and breathing tubes. Others at risk include individuals who have extensive burns or have experienced severe trauma, are previous sepsis survivors, and have low socioeconomic status and levels of education. Evidence proposes that socioeconomic status and level of education significantly impact sepsis-related outcomes. Some signs and symptoms associated with sepsis include fever or temperature greater than 101, low body temperature or hypothermia, elevated heart rate, increased respirations, altered mental status, very fast respiratory rate, shortness of breath, or low blood pressure, lower than 100 milligrams of mercury systolic. Patients may also have many other signs and symptoms that occur with sepsis, such as a decrease in carbon dioxide, chills, dizziness, fatigue, shivering, facial flushing, decreased urine output, skin discoloration and pallor. They may also exhibit symptoms of organ dysfunction and just be very lethargic. Signs and symptoms of severe sepsis include decreased urine output, abrupt changes in mental status, decrease in platelet count, difficulty breathing, abnormal heart pumping function or dysrhythmias, abdominal pain, extreme weakness, skin discoloration, and shock. The sepsis sequelae intensifies very quickly, and a patient can look as if they are fine and within a matter of hours exhibit signs and symptoms of severe sepsis and require assistance with ventilation or worse, pass away. Assessment and early recognition of symptoms is key to survival. As a sepsis survivor myself, I am here today because of the quick recognition and notification of symptoms by my nurse. If she hadn't been in tune with my condition, my outcome may have been very different. The stages of sepsis. The first stage of sepsis is the least severe and is usually identified by symptoms such as fever and an increased heart rate. The second stage is more severe and is characterized by symptoms of difficulty breathing and possible organ malfunctions. Keep in mind that there may be many alterations in blood pressure during this stage. While the third stage is the most severe stage and is characterized by symptoms accompanied with septic shock, it may also include life-threateningly low blood pressure. Mortality from sepsis increases by as much as 8% for every hour that treatment is delayed. And it is estimated that as many as 80% of sepsis deaths could be prevented with rapid diagnosis and treatment. The model on this slide is representative of Hans Selye's general adaptation syndrome. This theory paints a picture of the body's response to a stressor, or in the case of sepsis, an infectious agent, and thus illustrates the importance of early identification and rapid treatment, as these simple steps can interrupt the cycle caused by the stressor and help to move one back to a state of homeostasis. Selye explains that anything that causes stress endangers life unless it is met by adequate adaptive responses. In the concept of the general adaptation syndrome, Selye identifies that all potential stressors must be alleviated to ensure that the human body continues to function normally, which is essential for leading a healthy life. If maladaptation ensues, life is at risk. In most situations, individuals are readily available to enlist the mechanisms needed to alleviate the detriment of a stressful situation. However, in the case of sepsis, onset is often very quick, and those that are highly susceptible are not armed with the defenses needed to protect themselves. According to the theory, there are 3 physiologic responses that the body experiences when placed in a noxious situation: alarm, resistance, and exhaustion. When the body identifies the presence of an unwanted stressor, it sends out an alert and alerts the brain to activate the fight or flight response while seeking to either remove the stressor or flee the situation. This sequence of events is also initiated in the body when an unwanted pathogen enters the bloodstream. The body releases a cascade of inflammatory protectors to remove the source of infection. The body continues to fight and deploy its natural defenses. During the phase of resistance, the body is able to efficiently defend itself, adapt to the increased demands, and function as usual. However, as natural mechanisms of defense are unable to keep up with the pressures of adaptation, they eventually become inundated with the opportunistic pathogen and are unable to destroy it without outside help, such as fluid resuscitation or antibiotics. During the final phase, exhaustion sets in, and life cannot be sustained without assistance. The stages of the general adaptation syndrome illustrate the necessity of the initiation of treatment as symptoms of sepsis arise. The implementation of sepsis protocols and bundles that focus on early detection and treatment have proven to be successful in facilitating a return to a state of homeostasis, thereby reducing the incidence of associated disability and death. Unfortunately, if they are not deployed before exhaustion sets in, a state of homeostasis may not be able to be achieved. Sepsis is associated with high morbidity and mortality and accounted for $23.7 billion in healthcare expenditures in 2013, compared to a bit over $16 billion in 2007. The cost of treating sepsis patients increases 12 to 14% every 2 years. And in 2018, Medicare spent over $41.5 billion treating sepsis patients, treating their respective patient population. Sepsis is the #1 cost of hospitalization in the United States, consuming more than $27 billion each year. The average cost per hospital stay for sepsis is double the average cost per stay across all other conditions. And sepsis is the #1 cause for readmissions to the hospital, costing more than $2 billion each year.
The nurse has an important role in improving outcomes for patients experiencing sepsis. The nurse is often the first healthcare provider to assess the patient and certainly has more contact with the patient than any other healthcare provider. This allows for early recognition of signs and symptoms of sepsis, timely treatment, being a patient advocate, and providing patient and family education. Sepsis diagnosis is based on identifying 3 conditions: known or suspected infection, 2 or more of the clinical indications of the systemic inflammatory response, as described by Dr. Harden, and evidence of at least 1 organ dysfunction. Several early warning scoring assessments are available to facilitate timely identification of sepsis. Some facilities have sepsis rapid response teams. It's important for the nurse to understand what to assess as well as the rationale. Indicators of sepsis include general, inflammatory, hemodynamic, organ dysfunction, and tissue perfusion variables. And as Dr. Harden reviewed earlier, in the early stages of sepsis, there's massive vasodilation, which results in the patient's skin having color, feeling warm, and flush. The sympathetic nervous system response results in increased heart rate. Vasodilation results in decreased diastolic pressure, but systolic pressure may initially increase due to that initial increase in cardiac output. This results in widening pulse pressure. So initially the patient may have full bounding pulse, and the patient can appear to have a relatively normal blood pressure, even though they're experiencing severe sepsis. But the nurse needs to remember that septic shock can occur quickly as preload, afterload, and heart contractility decreases. According to the up-to-date database, which was last updated February of this year, the 2 most commonly used sepsis screening tools are the Quick Sequential Sepsis-Related Organ Failure Assessment Score, or QSOFA, and the National Early Warning Score, or NEWS score. The goal of screening tools, which provide an overall risk score, is to standardize the assessment process and the response. This slide shows the updated NEWS scoring system. I'm going to focus on the must-assess variables that are listed in the screening tool, along with rationale for each. Now, keep in mind that the QSOFA tool was originally designed as a predictive tool that calculates the risk of death from sepsis and not as a diagnostic tool, and that's why I'm presenting the new scoring system. You can see that the new scoring system is based on simple aggregate scoring, in which a score is allocated to a physiological measurement that's already recorded in routine practice when patients present to or when they're being monitored in the hospital setting. 6 simple physiological parameters from the basis of the scoring system are included. And I'm going to discuss each of these general variables that the nurse typically assesses for in all patients. Notice that the scores increase as the patient's values vary from these expected values in the center, so a score of 0, but the score increases to the right and to the left. Respiration rate, or breaths per minute, is listed first. And as Dr. Harden discussed, tachypnea, or that increased respiratory rate of greater than 20 breaths per minute in the adult, is a possible indication of early sepsis. Then the oxygen saturation measured by external pulse oximetry of a SpO2 is another value. So less than 96% would increase the score. Then if the patient is receiving additional air or oxygen, that automatically adds 2 points to the score. Systolic blood pressure measured in millimeters of mercury is listed on this tool as well. Arterial hypotension is characterized by a systolic blood pressure of less than 90. And you can see that that's here on the far left of the slide, so that would be the more severe score of 3. Although it's not listed on the slide, mean arterial pressure, or MAP, is also an indicator. So a mean arterial pressure of less than 70 millimeters of mercury would alert the nurse that there could be a problem as well. And a systolic blood pressure decrease of greater than 40 millimeters of mercury, or less than 2 standard deviations below what's normal for the age, could be an indicator. So some patients may not have the blood pressure of 111 to 219 as their normal blood pressure. Maybe their normal blood pressure is lower than that lower level. But if they have that systolic blood pressure decrease of more than 40 millimeters of mercury, then that could be a strong indicator of early sepsis. When measuring blood pressure, keep in mind that the sphygmomanometer may be unreliable in patients that are severely hypotensive, so an arterial catheter may be indicated. The next variable is pulse rate, measured in beats per minute. A heart rate of more than 90 beats per minute, or more than 2 standard deviations above what's normal for age, is a risk factor for early sepsis. Then level of consciousness needs to be assessed, and base level of consciousness assessment on the patient's usual level of alertness. New confusion needs to be seen as a change in level of consciousness. Another variable is temperature measured in degrees Celsius. Keep in mind that a temperature of 38.3 degrees Celsius is about 100.4 degrees Fahrenheit, and a temperature of 36 degrees Celsius is about 96.8 degrees Fahrenheit. In sepsis, temperature is often elevated in response to pyrogens released from the invading microorganisms, and in response to immune mediator activation, and also increased metabolic activity. Each facility should have a protocol in place for quickly alerting the rapid response team and the provider when we have increased scores on the early sepsis recognition tool. The aggregate score, or the score all added up for each variable, represents the risk of death from sepsis and indicates how urgent of a response is needed. For example, A patient with a score of 0 to 4 would have a low risk. A patient with a score of 5 to 6 would have a medium risk, and a score of 7 or higher indicates a high risk for sepsis. Nurses must also assess inflammatory, hemodynamic, organ dysfunction, and tissue perfusion variables to recognize worsening sepsis and progression to septic shock. As Dr. Harden discussed, some of the signs of decreased organ perfusion could include warm, flushed skin in the early phases of sepsis, but remember, as sepsis progresses to shock, the skin can become cool due to redirection of blood flow to those vital organs. The patient may also experience decreased capillary refill, cyanosis, or mottling of the skin. Additional signs of that decreased perfusion to the organs includes altered mental status or restlessness, and oliguria or anuria. Acute oliguria is manifested when the urine output drops significantly, so that would be less than 0.5 milliliters per kilogram per hour for at least 2 hours, even though you've given that patient adequate fluid resuscitation. Urine output declines because there's decreased perfusion to the kidneys. A lab indicator would be creatinine increase. And then with the intestinal effects of decreased perfusion, the patient may experience ileus, which the nurse would hear absent bowel sounds. And that's often at the end stage of that hypoperfusion of the organs. This slide shows an example of an early sepsis recognition screening tool currently used in one clinical setting. Notice that it's not the news tool that I just showed you, but it does have the same variables as in the news tool. The American College of Emergency Physicians recognizes the important role nurses have in early diagnosis and treatment of sepsis. And they recommend that nurses suspect sepsis or septic shock in obvious cases, such as those where the patient has fever, has elevated white blood cell count, and hypotension. But outside of these classic presentations, the nurse would suspect sepsis for unexplained altered mental status, tachypnea, that increased respiratory rate, even though the chest is clear and there's normal oxygenation, or if your clinical instinct suggests that something's just not right in a patient with what you think is a routine infection or suspected infection. This is the other page to the early sepsis recognition screening tool, and you can see where it includes evidence of acute neurological changes, and where you can total the score and then can add additional information such as creatinine, white blood cell count, and lactate levels. The nurse's role in treating sepsis is to minimize the time between recognition of sepsis and treatment. Therefore, early recognition is the first step. During this presentation, we're focusing on nursing interventions to implement during that first hour of treatment. Dr. Harden discussed care bundles. Sepsis care bundles were developed based on the best available evidence to bring sepsis care guidelines to the bedside nursing care. In 2018, sepsis bundles were revised by the Surviving Sepsis campaign. I'm going to review key elements of the Hour 1 sepsis bundle and apply this to the nurse's role. Once sepsis is identified, the nurse must begin resuscitating and management immediately. It's important for the nurse to know what to do, as well as the rationale for each intervention. There are 5 important activities that should be initiated during this first hour. During all interventions, the nurse needs to continuously monitor the patient closely for their response to the interventions. Patients can be transferred quickly to different nursing care units as acuity increases. Therefore, it's imperative to include the patient's sepsis status in the handoff report. According to the Hour 1 bundle, the nurse should measure lactate levels and remeasure if the first result is greater than 2 millimoles per liter. This is included in a variety of sepsis assessment tools. An elevated serum lactate can be a manifestation of organ hypoperfusion in the presence or absence of hypotension and is an important component of the initial evaluation. Elevated lactate is associated with poor prognosis. A serum lactate level greater than 4 millimoles per liter is consistent with, but not necessarily diagnostic of, septic shock. According to UpToDate, arterial lactate specimens are preferred over venous specimens. The next step is to obtain blood cultures before administering antibiotics, and this is best practice. The rationale is to facilitate accurate identification of the underlying pathogen. But antibiotic administration should not be delayed if there's difficulty obtaining blood culture specimens. Following collection of blood culture specimens, broad-spectrum antibiotic therapy is initiated. Then, after the blood cultures are resulted, the antibiotics can be changed to a more narrow-spectrum classification that's specific to the underlying pathogen and the sensitivity report. It's important not to delay fluid administration, even though the next step is rapid fluid administration. If the patient needs fluid, this might be the very first step that we do. Patients experiencing sepsis often have decreased perfusion and even septic shock, so rapid administration of crystalloid fluids is indicated for hypotension or elevated lactate levels. The nurse must continually evaluate and assess the patient's response to this rapid infusion. Crystalloid solutions are mainly used to increase the intravascular volume when it's reduced. And a common example of a crystalloid is 0.9% sodium chloride or normal saline. If the patient continues to be hypotensive during or after fluid resuscitation, then vasopressors can be added to maintain that mean arterial pressure to be greater than or equal to 65 millimeters of mercury. This level of mean arterial pressure is needed to perfuse the vital organs. Prevention of sepsis and septic shock is primarily a nursing role. The nurse should implement evidence-based measures to decrease the risk of infection, as well as assess for new infections. The measures include practicing and encouraging appropriate hand and personal hygiene. So this is for both the nurse, the nursing staff, and the patient and family members. Practicing and educating patients on care and maintenance of wounds, surgical sites, and indwelling catheters. Encouraging early ambulation or at least sitting in the bedside chair. Providing supportive nutrition, and completing and documenting thorough and timely assessments, identification, and reporting of symptoms of infection. And of course, adhering to universal precautions and using our bundle care protocols to decrease those invasive catheter-related infections. When providing printed patient education materials, keep in mind the level of resources and literacy abilities of the patient. For example, UpToDate provides the basics, which are written at the 5th to 6th grade reading level. These are plain language materials that address about 5 key questions a patient might have. But in contrast, beyond the basics materials are written at the 10th to 12th grade reading level. And these are most appropriate for in-depth information, and these do contain some medical jargon. So in summary, understanding the nurse's role in early identification and treatment of sepsis is integral to improving patient outcomes. And this includes understanding the risk factors, the signs and symptoms, being able to perform accurate and timely assessment, understanding the nursing interventions and related assessments, and then understanding and implementing the prevention measures, both for nursing staff, teaching the patients, and teaching the patient's family members. We thank you for listening to the presentation, and please feel free to reach out to us if you have any questions. Our contact information is listed on the second slide. We've included some references on the PowerPoint slide handout as well.